Welcome, everyone. My name is Mackenzie, and I am the Vice President for the Women in STEM. And we are a part of the Girls Who Code College Loop and the Women in Technology International, and we are very excited to get started.
Hello, everyone. My name is Lisa Sims, and I am the lead faculty advisor for our Women in STEM Club. And before we actually get started, I am going to have us to actually look at a poll, just kind of see where we stand. Okay. And our first poll question that we're going to start with today is we just want to see how many of you have had a loved one or someone you know diagnosed with some form of cancer. And I'll give you a few moments to cast your vote there. All right. We've got a few more people that are entering in, so I'll allow a few more seconds there. All right. I'm going to go ahead and end the poll and share our results. And so, as you can see, a good majority of us have been affected by either having a loved one or someone we know diagnosed with cancer. I know for myself, my father was diagnosed with cancer, and I don't like to say he lost his battle. I just say he no longer has to battle cancer anymore. And so let me launch our next poll. All right. The most common type of cancer, what do you think that is in the United States? And I had to look this one up just to be sure. Right, I'll give it a. Okay, we have lung in the chat. All right, I'm going to go ahead and end the poll and share the results. Okay. Breast cancer is the cancer that has received 70%. And those of you that said breast cancer, you are correct. Breast cancer is the leading cancer in the United States. And so I was surprised when I did my research on that particular topic. And also, I just want to let you know, February is Cancer Prevention Month, I believe. And so we're doing this because we want to help you to not only think about how you can protect yourself from cancer, but just doing those things that you can do that are preventative steps to help you with cancer. Give me 1 second. Let me. Can't launch that particular poll. All right. For some reason, I can't launch my next poll, but if you utilize the chat for this one, colonoscopy screening. At what age do you think you should get a colonoscopy? Starting at age 45 or earlier? Starting at age 50? Or starting at age 55? And if you could put your answer in the chat. Right, we have, let's see what we have here. So far, let's see, we've got 45 or earlier, 50, 45, 50. Okay. Well, those of you that said 45 or earlier, you are correct. Now, if you said 50, you are technically correct as well, but the standard has moved to 45 or earlier to have your colonoscopy. So if you have not scheduled your colonoscopy, make sure you do that. There are ways that you can, if you didn't want to do the colonoscopy, I'm sure you've seen the commercial for Cologuard. If you're not in the high risk category, I'm not a doctor, don't want to give you any, I'm just letting you know what your options are. I'm just letting you know. But I just want you to make sure your colon is fine so that you can be around for your loved ones. And so thank you for participating in our poll. And so now I am going to turn it over to Mackenzie, who is going to introduce our speaker. Mackenzie?
Thank you, Lisa. Dr. Christina Henson is a physician and assistant professor in the Department of Radiation Oncology at the University of Oklahoma. She obtained her bachelor's degree and medical degree at the University of Oklahoma and now treats patients with head and neck cancer and breast cancer. She lives in Oklahoma City with her husband and 2 children, ages 7 and 4. Thank you.
Thank you, Mackenzie. And thank you guys all for having me today. I'm just really excited to be here talking with your group, and I look forward to hopefully chatting with you guys a little bit and answering any questions, and also hope that you learn a little bit about the field that I care very deeply about. Lisa, you gave a great kickoff. Those were really, really great questions. And I would say that pretty much everybody has been affected by cancer in some way, whether it's been themselves or a loved one, a friend or family member. It's hard to find someone who doesn't know somebody who has had cancer. So I'm gonna, let's see, can I X that poll? Okay, you guys can see my slides okay?
Yes.
Yeah, okay. All right, I'm gonna kind of quickly go through the slides and then just kind of chat about some of the questions that I think you guys sent me in advance, which I appreciate, just about STEM careers in the field of radiation oncology and in oncology in general. And I'd say there's probably a field, a STEM related field in oncology, no matter what branch of STEM you're in or your interests are. And I apologize for my voice. I'm slightly under the weather, but we're going to make it. So I'm a radiation oncologist, and in general, for patients with cancer, there's 3 broad types of treatment that they can get. They can get surgery, they can get chemotherapy, and they can get radiation. And depending on what type of cancer they have and what stage of cancer they have, we'll use 1 or 2 or all of those things, just kind of depending on the situation. And I'd say that the radiation component is probably the least known about by like the average person who hasn't known someone who's been through it. So there are people who make it through medical school and still don't know about the existence of this field. I'm going to close my Teams real quick so that you guys aren't having to see those pop-ups. So I'll tell you a little bit about what this field entails. So radiation has been used for over 100 years to treat cancer, and more than 60% of patients who get diagnosed with cancer will receive radiation treatment. A lot of women with breast cancer get radiation treatment, and as you know, Lisa taught us, that's the most common type of cancer nowadays. One in 7 women will get diagnosed with breast cancer in her lifetime, and men also can get breast cancer. And so there's a whole team that goes into treating patients with radiation. In this picture, you see a patient who's laying down for radiation treatment, and this is a radiation therapist who's getting him positioned for his treatment. So the basis for radiation therapy is that we're using radiation, which can be either in the form of photons, protons, or electrons. And we're using that radiation in a focused way to damage the tumor. And basically the goal is to cause DNA damage to the tumor cells so that they can't replicate anymore. And then they just die and go away. Because cancer is a dysregulated division of cells. They're dividing and multiplying too much. And so if we can damage the cell's DNA, then the tumor cannot keep growing. So that's how radiation works. In a perfect world, the radiation would only hit the cancer cells, but that's not the case yet. There's always a little bit of collateral, a little bit or a lot of collateral damage, depending on what part of the body that we're treating. So the patient's normal tissues. So in the case of someone's breast, they're going to get skin irritation. And then you think of the organs that are near the breast. So you've got the lung right under it, you've got ribs, got the heart nearby. And so all of those tissues get some radiation exposure and are at various risks of having issues with those things from our treatment. So it's always a risk benefit assessment. We only do radiation treatment in situations where we feel like the benefit will outweigh the risk. Same as surgery or anything else. That's part of practicing medicine. So let's see, I'm going to skip some of this. We don't need to get too much into the nitty gritty of the biology of radiation, because that can get a little bit boring unless you're taking a whole class about it. But our clinical uses of radiation we can use it to try to cure a cancer, or we can use it to try to help a patient with symptoms. So that, sometimes we see patients who have cancer that's not curable at the stage that they're at. And radiation can be used to help with pain, to help shrink a tumor that might be very close to their airway or causing them problems swallowing or impinging on a nerve, for example. So we can use it either to cure. In those cases, we're usually willing to accept some side effects with our goal of cure. Or we can use it to try to make the patient feel better, knowing that we're not going to try to cure the cancer. So we definitely work as part of a team. We work really closely with usually the surgeons that are oftentimes surgery is part of a patient's treatment. For breast cancer, that's pretty much always the case. For colon cancer, that's pretty much always the case. So we're working closely with their surgeon, with their chemo doctor if they're getting chemo, and then within the radiation team itself. And we've got physicians, we've got radiation therapists, we have physicists that work in our department. We have nurses, we have medical assistants, we have PAs and nurse practitioners. There's a whole field called dosimetry, and I'll explain that a little bit more later. But there's a whole gamut of people that are part of the team. And so some basics. So this is a patient who's getting their chest radiated that looks like they've had a mastectomy. You can see a scar right there. So they had their breast removed for breast cancer, and now they're having radiation. You can kind of see the side effects that this person's experiencing. A lot of skin redness, some peeling here in the underarm. It's basically kind of like a bad sunburn. Can obviously be pretty painful. So when patients are getting radiation treatment, we see them very frequently to help them, help advise them on how to manage the side effects that we're causing. And here's a list of just some common side effects that can happen depending on what part of the body we're treating. So, when someone gets chemo, it goes into their vein and it goes throughout their whole body. And so with chemo tends to cause things like nausea and really significant fatigue, hair loss over the whole body, changes in fingernails, things like this. Radiation really just causes side effects in the area that we're treating. So, like I said, when we're treating the breast, we can cause skin redness, we can irritate the underlying lung. If we're treating someone with cervical cancer, we can cause them to have abdominal cramping, we can cause bladder irritation. If we're treating prostate cancer, again, bladder irritation, diarrhea, erectile dysfunction. So really kind of case by case, it depends on what body part we're treating. But as radiation therapy technology has evolved over the decades, we have been able to decrease the amount and the severity of side effects, but they're definitely still there. So again, there's several members of the radiation oncology team. There's the radiation oncologist who's the physician. We have a whole team. So in my group, we have 9 physicians. We have 9 medical physicists, and some of them have masters in physics, and some of them are PhDs. But they do a lot of the like machine calibration. We test each plan on a dummy patient, essentially, a dummy that we have, and that's called QA, or quality assurance. So we QA each patient's plan before the real patient shows up. And it's our physicists that do all those machine checks and quality checks that are so important, because if 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 we think what we're delivering is not what we're delivering, then that's bad. Our dosimetrists work with us and the medical physicists to help design the radiation plan. So when we're going to be treating someone, we bring them in for like a dry run where we set everything up. We maybe draw the area that we're going to treat, or we get a CAT scan through the area that we're going to treat. Basically, we outline the tumor that we want to treat, and the dosimetrist is the person who basically brings our plan to life. So they work on a computer all day, kind of working with the different software and algorithms to make all these things actually happen. The therapists are the ones who actually are hands on the patient every day. So that they get the patient onto the table, get them positioned in whatever way has been prescribed. And so they're kind of that like front line with the patient that's seeing them every day. And then obviously nurses are a really important part of our team too, just in helping us take care of these patients on a day-to-day basis. So when someone comes for radiation, they've usually already been given their diagnosis. So it's not very often that the radiation team is having to tell a patient that they have cancer. That's more often the surgeon who's done the biopsy. So usually by the time they come to us, they've kind of started to process, and they're ready to hear about, okay, what's the plan? Like, what's the action plan going to be? A big part of why I like treating cancer patients is because I am not a patient person. And preventative care is so important, but it requires so much patience. And, God bless the primary care doctors who are out there every day trying, telling the patients what they need to do, take care of yourself, get your colonoscopy, get your pap smear, these things. Part of why I love oncology is because patients are just really ready to do the thing when they come to you. They're ready to do it. And we get to have really, really interesting conversations with people. When someone has a cancer diagnosis, it's probably, if not the hardest time of their life to that point, it's one of them. And so we get to kind of walk them through that process. And I say I learn so much from my patients, just because they have this wisdom that has come with going through this, that it's really, really beautiful. So one of my favorite parts of doing what I do is kind of the like psychological side, I guess, and just the relationships that we get to develop with our patients in this really intense time. And they're coming to our clinic like every day, usually for about 6 weeks during treatment. So we do get to be pretty close with each other. So yeah, a patient comes to us, they've been referred by their surgeon. We talk about what we recommend. We talk about what's important to the patient. What do they want? Sometimes there's a lot of options involved. So we kind of talk them through all those options, see what they want to do. And then once they've made the decision to do radiation, we proceed to the treatment planning, which is usually involves sorry, these pictures are so outdated. You can tell by the hairstyle. We get the patient into the position that we're going to treat them in. So for a patient with head and neck cancer, or brain cancer, or throat cancer, anything kind of up above the collarbone, whatever part of the body that we're treating, we have to keep it really still, because again, our plan is only as good as our ability to reproduce it every day, right? If we think we're hitting our target but we're not, then that's not going to go well. So we got to keep things still. So for a head or a neck, we make this mask that's basically it's a really floppy plastic that is stretched over the patient's head and shoulders. And then over about 10 minutes, it hardens and it stays that way. And so every day that they come for treatment, we pop that mask on, it gets their chin and everything in the exact same position every day. So if we're treating someone's foot, you know, you don't realize how much your foot moves when your hip moves or when you're slightly rolled on your pelvis. So we have all sorts of devices that we use to keep people super still. Sometimes we use tattoos as well. We've kind of started to get away from that because there's alternatives now. And a patient hopefully isn't left with like a permanent mark of their treatment, but there are situations where we do still use tattoos. So once that has been done, we do the planning, which is all computer based. So you can see these two. I need to put some new pictures in here with ladies. These are not my slides, but these are all dudes in these pictures. But most of our planning is done on the computer, and it's based on CT scans. And CT scans are the reason a CT scan looks the way it does with the contrast of the different body parts is it's all density based. So bone is a lot more dense than air, which is a lot less dense than muscle. And so the way you get that really nice picture is by density differences. And we also utilize those same density coefficients to know how deep our radiation is going to be going based on what type of tissue it's going through. So then once we have a plan, it goes through lots of safety checks. Like I said, the physicists calibrate the machine every day. And then there's a rigorous quality assurance process that makes sure that the plan technically can be delivered, that we're not using angles that aren't actually possible based on where, for example, the patient's arm might be. Is our machine going to actually clear that body part? Things like that. And so those are done for each patient getting treatment. And so then once it's time for the patient to actually get their treatment, they basically come in every day and lay on a table that looks like a table you'd lay on for a CAT scan or an MRI. And the patient doesn't feel anything when the radiation is going in. It's like getting an X-ray. You don't feel anything. Side effects take days to weeks to develop. And the units of radiation are called gray, or centigrade is what we use a lot. And the term rads is kind of an older term. And then we can also do radiation that's done internally, where the patient's either opened up in the operating room or we're placing instruments under sedation or anesthesia, for example, for cervical cancer. That's still the best way that radiation can be done is by placing instruments into the patient's vagina and cervix. And so that's almost a more surgical procedure. So if someone who's a little bit more on the surgery side and likes more procedural types of things, radiation oncology still offers that. So there's a whole lot of different types of radiation that we can use. And I mentioned electrons, protons, and photons. And these are all kind of different versions of that. Most people in most cities, at least most big cities, have a proton center, and you probably hear their commercials on the radio. And we do have proton therapy at the University of Oklahoma as of 2019. So we've had it for a few years now. But it's just like anything else, the commercials will say, like, you won't have symptoms, that, proton therapy does not treat your normal tissues, and that's all pretty overblown. So proton therapy is not magical, but there are definitely situations where it is a good tool that we have. So again, this is a dosimetrist probably who's sitting here reviewing a plan, and you can see all the different beam angles that are coming in to treat this, what looks to be a a thyroid tumor potentially extending down into the chest. Um, and there's all sorts of different computer-based renderings of our treatment plan that we can look at. Um, and sometimes we'll use little markers to if there's certain types of tissue that we just can't see very well in an x-ray. So this is somebody with prostate cancer, and you can't see the prostate on an x-ray. So we can either get a CT, sometimes there's a CAT scanner built into the radiation treatment machine. So we can get a CAT scan every day to confirm that the prostate is in the location that we need it to be in. Or patients can have little markers placed in their prostate. And we also do this in the cervix for women with cervical cancer. We also do this for breast cancer, where our surgeons will place little clips in the lumpectomy cavity, that then we can see them much more easily on our x-rays that we're doing at the time of treatment. It just increases our confidence that we're hitting the right spot, basically. Stereotactic radiosurgery it just means high doses of radiation and a small number of treatments. So it's usually done for really small targets. For example, like very small brain tumors or very small lung tumors. And this is I've actually never seen a setup like this, but this is someone whose entire body is being immobilized for some sort of treatment. And this whole contraption is connected to a vacuum system. You can see this tube coming off the end. That's a vacuum system. And it's basically just sucking all the air out of this thing around him so that it's really tight and snug on his body. So protons, so normal radiation is photons, which you guys know what, I'm sure you guys know what you guys are in the STEM club, you guys know what photons and protons are, but protons are heavier than photons and they're charged. And they have very different characteristics of how they behave when they're going into tissue that we can manipulate to our advantage. So photons go all the way through you. They go in one side and out the other. That's why they're used for x-rays and CAT scans, because they go through you. They go onto the film or the receiver on the other side and make a really nice image showing the density differences. Protons don't go all the way through. They go a certain depth and then they stop. So when we have a tumor that's really close to a really important structure, sometimes the protons can go a prescribed depth and then stop short of that important thing. So those are situations where we often do use protons. So the most common good reasons to use protons are in pediatric cancers, brain cancers, and cancers of the eye. But there is increasing data for using protons for other things like head and neck cancers, breast cancer in some situations. We can get a lower dose to the heart if we use protons. So it's really I really like having both technologies just because they're cool technologies, but also because then we can do both plans and pick which one looks the best for that patient. This is what our proton unit looks like, which is really cool. It has this giant, so I don't know if you can see this tiny black thing in the middle is the couch that the patient lays on. So that's to give you a sense of the scale. So the actual unit is huge and is usually housed behind the wall. So this is the treatment room. This is where the patient lays, and there's a ceiling here. So they can't see all this behind them, but that's a giant, that's a cyclotron with two giant magnets in it. And it's just really cool. And it rotates around the room that the patient is being treated in. So I talked a little bit about implantable radiation that we do for prostate, cervix, used to do for breast cancer, but now we have better ways of doing that. But so when we do brachytherapy, just means radiation that's done through the inside of the patient. And when we do that, this is like for prostate cancer, we'll sometimes place little tiny radioactive seeds within the prostate that stay there. decay over time, and then they become inert and they're just a part of that patient's body after that. But this is how big they are. And there'll usually be about 20 inside of for a prostate, but they're tiny, but they're very radioactive. So these are placed in the operating room, and then once they're all placed, we have a radiation detector that's kind of taken around to make sure that none of these fell on the floor or accidentally went in the trash, because that can be easy to do with something that small. And this is what that looks like on a scan afterward. So these are inside somebody's prostate. You can kind of see the shape of it because of where they are. And this is just a catheter balloon that's in this patient's bladder. And let's get some of this. So radiation can also be given systemically, meaning where a patient ingests it, or it's given through an IV and it goes throughout the whole body. So that is most often done for patients with kind of diffuse bony cancer, like bone metastases from prostate cancer. It's often used for. It's also used for thyroid cancer. So thyroid cancer, a lot of people know somebody who's had thyroid cancer, and often that is treated with surgery and then with basically a radioactive pill that the patient takes that just kind of cleans up any stray cells that were left behind. But it's a lot lower dose of radiation than the external radiation. So just increasing public awareness of like the existence of radiation therapy. So patients report that they'll often go to friends and family, and then also to their primary care doctor to get advice on their cancer treatment. And so it's important that everybody in the community kind of be aware, at least on a broad level, of different types of cancer treatment and what their family member might be going through, and then they're able to ask questions on behalf of themselves or their loved one and kind of advocate better for themselves. So in summary, radiation therapy is a kind of a long-standing, well-established technique for treating all different sorts of cancer. There are all different types of ways that we can deliver the radiation. And again, I didn't make this slide, so I don't necessarily agree. So the treatment itself is painless. But I feel like that's a little bit misleading because the side effects are always painless, but the treatment itself is quick and painless, just like getting an X-ray. So if you're interested in learning more about just what is radiation oncology, what are careers in radiation oncology, these are some resources. ASTRO is our big professional organization, stands for the American Society of Radiation Oncology. That's our kind of big group that everybody's a member of. And so that's all for my slides. So I'll stop screen sharing. Let me take a look at the clock. I think I'm doing okay on time.
You are.
Okay.
And
So
we've got some questions in the chat if you want to.
Okay, yeah, for sure. Let me pull it up.
I can read them out to you and everything.
Okay, that'd be great.
Let's see. Dr. Ivy has a question, or Dr. Ivy, did you want to unmute yourself and ask your question? Either way.
Okay, I had to go back and see, what did I put in there? I put a couple of ones in there. Okay, first question is, Dr. Henson, how has technology enhanced the radiation oncology field over the years?
Yeah, in a lot of ways. It's such a rapidly changing field. I think one of the biggest ways is, as diagnostic imaging, diagnostic radiology has come so far. So we used to just have X-rays, right? That someone had to take the film and put it up on the lit box to read the X-rays, and now we have really fancy CAT scans and MRIs where we can before we could see tumors really well, we were in a position of just having to treat a bigger area because we weren't sure where things started and stopped, right? And now that we can see things so much better, we can treat smaller areas. There's also been a lot of research done that's helped us to be able to tailor treatment better to a patient. So as we look at large numbers of patients over the years, we can and have like biomarker tests and stuff. Now we're slowly getting better at saying, okay, this patient might not derive a lot of benefit from radiation because based on this genetic panel we did on their tumor, it's at a really low risk of coming back. So maybe they can avoid getting radiation. Whereas maybe this person's genetic profile of their tumor shows that it's super high risk and they need, this plus this investigational therapy. So those are just a couple of many ways that technology has helped us.
Thank you.
Yeah.
It's good to see all the computers as well.
So many computers.
Yes.
Yeah, that's part of why I like the field too, is because there's so much physics, and there's so much that we do with reading images on a computer, but then there's also so much time that we get in clinic with the patient. So it's a good mix for me, a good variety of face time with patients, but then time to geek out about everything else.
And I see Mackenzie had a question. Mackenzie, did you want to state your question or?
Yes, ma'am.
Yeah.
I was going to ask Dr. Henson, what is the best advice you can give someone before they start radiation treatments?
Yeah, a couple of things. I tell them to try to maintain their normal routine as much as possible, right? Without pushing themselves too hard, but to radiation and cancer treatment's very stressful, and I think can make a lot of patients feel like they're not themselves, right? And so I think as much as they can feel like themselves during treatment as possible, the better. I always ask them who's their support system, make sure that they have a support system. So if they feel like they're really tired and they need a ride one day, do they have somebody that they can call for a ride? If they don't feel like making themselves dinner one night and they realize that their fridge is empty, do they have someone they can ask to pick up dinner for them or grab them some groceries? And then kind of related to that, and also related to Karen's next question about soft skills, so many people are not used to talking about their feelings, especially men. And we'll have so many patients come in who are so clearly wound up, so tight, but they can't even see it. But we have really, really great counselors and psychologists available at the cancer center. And so I've just started telling every patient, I offer this service to everybody, but we have really great counselors here. Would you like to talk with them? And they can also speak with your family, or if they have children that are having to also deal with their parents' diagnosis, they can kind of help everybody. So I really try not to ignore my patients' psychosocial needs. I think sometimes you can get so busy, it can be hard to remember to do that instead of just focusing on, okay, this is the cancer treatment, but the other part is just as important.
And
Thank you.
I've got a question for you. So when did you know that you wanted to be a doctor and that you wanted to kind of specialize in the cancer field?
Yeah, I feel like I figured out in high school that I wanted to be a doctor because I really like working with people. I like the excitement of working in medicine. You are kind of on your feet a lot. There are, acute situations that you're having to deal with. It's a pretty busy pace, which I like. And when I kind of knew I wanted to do something to do with cancer going into medical school. I think just what I learned about cancer in college and my science classes, I found it so terrifying and so interesting. And, it's on the rise and no one can figure out how to fix it. And like, I want to treat this disease. And I also want to participate in research to try to help figure out how to cure this disease. So, I knew I wanted to do something in oncology. And so then in medical school, I got as much oncology related shadowing and opportunities as I could. So when I was on my pediatric rotation, I asked if I could rotate on the pediatric oncology ward. When I was on my OBGYN rotation, I asked if I could spend time with the gynecologic oncology surgeons. And so I just saw as much cancer, as many different types of cancer careers within medicine as I could, so that I could decide. And then I decided on radiation, kind of for the reasons I was telling you guys about it. You're not just in the OR all day, you're not just in clinic all day, you're not just sitting in front of a computer all day. It's kind of a really cool mix of all of those things. There's no boredom. Mhm.
Okay. Does anyone else have any questions? I have a question, but I don't want to monopolize, so I, I want to give somebody else a chance to ask a question.
Yes, this is Barbie. I was going to ask a question as it relates to the slides.
Mhm.
I know, Dr. Henson, you skipped over the consultation slide.
Oh yeah.
I recently, I had experienced very bad stomach pain, so I went to visit a GI, and the GI recommended a PET scan, a CT scan, and an ultrasound. Of course, the CT scan, I'm allergic to seafood. So immediately when the iodine went in, I just vomited everywhere.
Oh
And
no.
I burst a blood vessel in my right eye. So that was crazy. But I have a consultation with an oncologist on March 1st. So I kind of wanted to know what does that entail?
Yeah.
I
So, oh yeah, continue.
So I got a phone call from a nurse a couple of days ago. My high school alumni association voted me for president. So we're planning our 40th reunion. So it's just so much stuff going on. But the nurse was calling to tell me, oh, nothing was there. We didn't see anything. Everything looks good. And I said, well, apparently you didn't see my test results because I've had all this, that, and another. I just met with my primary doctor. And of course, he didn't tell me anything. So I'm really curious to see the oncologist just to see, what are next steps. Not saying I have cancer, but they did see a small mass in
Okay.
my uterus. So just wanted to
Oh, in your
get
uterus.
an
Okay.
idea.
Not in your stomach. Okay.
Correct.
Okay.
But
Okay.
but the pain started in my stomach. So I
Gotcha.
guess through all of the scans, that's when it came up. And when I had the ultrasound, when I was getting dressed, I guess the technologist, the specialist wanted me to see the results. So she left the imaging on the screen so I can kind of see what was there.
Okay. Okay. So I think at your visit, they're probably going to talk to you about that. I imagine they're probably going to want to do a biopsy of
Yes.
something just to make
Mhm.
sure that it's nothing to be worried about. So I think that at your consultation, since it, hopefully we don't have a cancer diagnosis, they're just
Right.
going to be talking you through the procedure that they're going to recommend to just evaluate it,
Okay.
completely. Hmm.
Okay. Just wanted to know what that will, what that entails. And of course, I'm in my last year of school, so I'm an emotional wreck trying to stay
Right.
focused, taking the last class. So, and then I have a sister who was diagnosed with breast cancer
Okay.
a couple of years ago. And although she feels as if the mass is decreasing, she of course she went through chemotherapy. Then she took the cancer pills, and then she started the shots, but no reduction in the mass in her breast. And so now she's taking some more pills that of course will cause sores in her mouth and
Mhm.
this and another. But should she immediately ask the doctors, what about removing the mass, or what are the options there? Because I'm in her appointment sitting there with her, and no conversation around removal. It's just the treatment, which apparently is not working.
Yeah. So for breast cancer, if it has already spread to other parts of the body when it's diagnosed, they don't
Mhm.
always remove the main tumor,
Mhm.
unless it's causing someone pain or it's bleeding or draining. So
Mhm.
I suspect that's probably what was the case for her.
Mhm.
Yeah.
Okay, because they're saying it's right now just limited to her breast, her right breast.
Okay, okay, okay. So if it's just limited to the breast, then yeah, I feel like at some point someone would at least discuss surgery with her.
Mhm.
Oftentimes chemo is done first though, to try to
Mhm.
shrink it before the surgery.
Okay,
But yeah, I would request a visit with a breast surgeon.
okay,
Mhm.
okay. I'll get with her again. She often asks that I attend all of her appointments with her.
It's good to have a second set of ears because
Yes.
usually the patient's pretty stressed and overwhelmed in those situations. So it's good to have a note taker.
Mhm.
Yeah,
Yes.
that
Okay.
goes for you too.
Thank you so much.
You're welcome.
And Barbie, we're going to be praying for you as well
Thank
as
you.
your sister, and so sending up good prayers for the both of you. If anyone else, does anyone else have a question? If not, I want to allow Dr. Ivy enough time to share her testimony before anyone has to leave, because this is very important, and I think this is going to really bless a lot of people. So without further ado, I'm going to turn it over to Dr. Ivy.
All right. Ask questions. That's one of the first things I want to say, Barbie, as you're in those sessions with your sister. And as Dr. Henson said as well, ask the questions. We need to know our own bodies and be the advocates for ourselves as well. So if there's ever anything that you feel you're not receiving in the meetings with your oncologist or other doctors, prompt those questions and they definitely will address those for you. So guys, on the screen is me, 2015. And this is me as I had finished my cancer treatments. So as Dr. Henson talked about the different types of radiation and the different types of treatments that you may receive, one very interesting thing with this picture, like I said, this was the end of my cancer treatments. This was the end of my second round of breast cancer treatments. 15 years prior to managing this round of breast cancer, I was diagnosed with breast cancer for the first time. That was around 2000 for me. Now, I want to say something. At the beginning, we asked the question, we had the poll as far as, I believe the question was on colonoscopy and what are the good ages to receive your first colonoscopy. So I was 38, I believe, when I was first diagnosed with breast cancer. And that was earlier than the typical time when the recommendation is provided for individuals to do your mammography exams and follow up with doctors in that area. So my message to everyone as I speak on breast health and recommendations for that is, number one, know your body. When a change occurs or changes occur in your body, you're the best person who knows that something feels different. Something is different going on in my body. I think I need to get this checked out. Or friend, here, can I help you feel what I'm feeling? What do you think? And ladies, I tell everyone, your husband, your boyfriend, your man, when it comes to your breasts, usually they know your body too. So be sure you ask them, honey, I'm feeling something different. What do you feel it? What do you think, right? As well. And definitely follow up on it with your doctors, right? So that you can get it checked out. So here's me at the end of my treatments, going through my breast cancer treatments. The first time that I was diagnosed with breast cancer, Dr. Henson talked about radiation. I did receive radiation treatment, and I also went through surgery for removal of that breast tissue in the spot. And it was just a portion of the tissue that was removed at that time, a lumpectomy. But 15 years later, same side of my body, of the breast, oh my goodness, here is another lump. It wasn't a reoccurrence of the same breast cancer that was there before that had been removed. This was a new location of the breast that occurred. And so needless to say, because this was my second go round in dealing with it, and also for African-American females, it is very typical for our tumors to be very fast growing tumors. Also hard to find as well. We have very dense tissue in our breast. And Dr. Henson talked about the different types of 3D machines. There's a more current mammography exam machine to deal with women with very dense breast tissues, right? I would recommend that for African-American women. So my second go around, it was a different breast, a different cancer location that occurred in my breast. And because it was the second time, there was no question of full removal of the breast, mastectomy. And during that second go round, I encountered the third oncology treatment that Dr. Henson mentioned, and that was chemotherapy as well. And I'll talk a little bit about chemotherapy a little later. So when you're dealing with breast cancer, or when you're dealing with family members who have been diagnosed with cancer, any type of cancer, I can tell you guys, for me, I was clueless. I didn't know a thing about cancer, not a thing about breast cancer. And so what did I do? I immediately started doing research. I went online, started Googling, right? Searching breast cancer. How do you treat breast cancer? How did I get breast cancer? What is going on? And so one of the things I definitely would recommend for anyone, if you're dealing with any cancer types of diagnosis, or you're helping a family member dealing with that, you yourself do research. You yourself do research to support your family member or close one who you are supporting dealing with cancer as well. And today we have some advances in technologies that even help us to do some of that research. So these I just pulled a few screen prints. This is just a few. I did a lot of research, right? But today there are AI tools where you can go. ChatGPT is one, right? What does ChatGPT do? It goes out and pulls sources for you on your behalf. When you are going and pulling information from online, don't use that as your source or Bible. Always check with your doctor. You can go to your doctor and say, hey, doctor, I pulled this information, and during my meeting, I have some questions, and I'd like to ask you those questions based on the information that I have read. But I definitely would recommend to do your own research as well. During the process, right? As I said, during my second go round, during the first go round, I did surgery and radiation treatments. I did 6 rounds of radiation treatment. During the second go round, I did surgery, was a larger removal, right? The full breast. And I also followed that up with chemotherapy. I would recommend with anyone, use technology to document your story. And that's what I did. I had a friend of mine, and he said, you know what, Karen, I'm located in Colorado. All of my family members are in other states. And he said, they are worried as heck as you're going through all of this, and they couldn't physically be where I was. So what did we do? We used technology to document my steps, document the process. We took pictures after every chemo treatment that I had, and we used texting to send to my family members, this is Karen, either during her treatment or after her treatment, and she has, you know, some words to say, and I usually would put something in the texting to share with the family members as well. In some of these pictures, you'll see me holding up fingers. And what that usually is signifying was the remaining number of chemo treatments that I had to go through to complete my chemotherapy process and treatment that I had. So I'll focus on the upper right-hand corner. That is me actually in the infusion area where I was receiving my chemotherapy. So guys, you see that laptop in front of me. And so if anyone has never been in an infusion unit or know how it works, people may be watching television, reading a book. I was online and I was getting some work done. And so technology, once again, was right there. Why is that important? And why was that important to me? Sometimes we may think when you're going through a very serious treatment and process in your life, everything stops and you just focus on that process. Depending on who you are, will drive what's best for you. But what was best for me was to maintain a balance in life. And maintaining that balance in life, I was able to continue getting some work done. I had my music with me sometimes, right, for enjoyment. Sometimes I even brought my own movies as well, while even going through those infusion units. But technology came in to assist me through the process, to assist me in communicating with my family members located all across the world. So they were not able to be there, but they could somewhat walk the walk with me as I was going through each of those units. The one on the left holding up before Arches Pizza, from anyone who is from Missouri, we have some pizza back in Missouri that is so good, Emo's Pizza. And Arches was a pizza that was branded just like Emo's Pizza. They used the same components that was located here in Colorado. So, just sharing different things like that to family members was very, very helpful and helped to ease some of their concern as well. Living your life and celebrating, even as you're going through, right? Very serious things. Barbie, as you're supporting your sister, going through her diagnosis and whatever her treatments may be, you're going to be right there to be sure that she continues to live, she continues to thrive, she continues to focus on her life, even on the other side of treatment, right? And how that may look and what she may be doing. And so I said, we use pictures and technology to give a chronological view in digital footprint of what I was doing during those times and going through treatments. In the middle, you see me holding up 2, that meant only 2 more chemo treatments left. Look at me now, right? And that's what I was doing. And on the right-hand side is one of the things that happened with me is I connected with other women who were dealing with breast cancer. And after I finished my treatment, we actually started a breast cancer support group. And so on the right, I'm going to advance. Probably, I guess I didn't put that in there. There was another picture that showed the fullness of it, but this was a Stomp Out Breast Cancer initiative. It's actually at the end, and I'll get to that picture. And all of the breast cancer survivors got to walk the walk, right? In our pink, wear it proudly, and so fully be there to share our stories of breast health, the stories of knowing your body, the stories of 3 key things that I'm going to share with you next to be sure that you're checking women for yourself, sharing with your loved ones to be sure they're checking as well. Number 1, your breast self-exam. Be sure on a monthly basis you are doing your breast self-exam. Like I said at the beginning, you know your body. When I first found the lump, I found the lump. My first go round and the second go round as well. But the first go round, I found the lump before the x-rays found the lump on me and I went to the doctor. The second go round, because I was used to doing my breast exams myself, I found that lump again, right? But this was sort of different. That second time, that lump was really embedded very close to my chest bone and very hard to access and very hard even to see on exams. So that's when I asked that question to Dr. Henson about the advancements of technology and how that really has enhanced the whole oncology field. It's amazing, just amazing how technology helps. Number 2, your mammography exam. Be sure you are getting your annual mammography exam. If your doctor is not recommending it, we talked about being your self-advocate. Ask your doctor for it, right? To be sure that you are receiving that exam, and also talk to your doctor about possibly having dense tissue, breast tissue. Your doctor will know and can tell you if indeed they would like to recommend you to use some of the newer mammography exam machines that can help to assist individuals better who have the dense breast tissue. Number 3, your annual visit to your OBGYN. Be sure you don't take that off from your list. Be sure that you are going to your doctor, you are asking your doctor to do your annual physical review. And if your doctor happens not to mention it or happens not to do that review for you, you request it. And be sure, if the doctor is doing the annual exam on you and you have questions during the exam, you pause and you ask those questions to your doctor. Your doctor will answer it for you, and he will address all of your questions. But this is your body, your health. Be sure you're taking care of yourself. And then the last one was that full picture I was talking about, being sure that you celebrate life. If you're supporting anyone who is dealing with breast cancer or any type of cancer, help them walk the walk as they're going through. Help them focus on their life on the other side of their treatments, and be sure they are enjoying life and celebrating life as well. And that's what I wanted to share with you guys. A 2-time breast cancer survivor. I am in the database. Anyone else who has survived any type of cancer, especially multiple times, your history, your walk goes into the database that other doctors will access and they will use. And why? Because your walk and how treatments impacted your body positively or negatively, successfully or not successfully, that information is becomes data that's collected, data that's available to other doctors and analyzed, as well as they not only are supporting you, but supporting anyone else who walks the walk in dealing with that particular cancer or something similar as well. So I would like to pause and open it up for anyone who may have questions for me.
Don't be shy. Anyone, you can put it in the chat if you have any questions.
I just wanted to say thank you for sharing that. It's a beautiful story and you're super inspirational. And I especially think your points about self-advocacy are so important. And, we do know our body's the best, and, doctors make mistakes and forget things. And, sometimes there's different sets of guidelines. Like there's one organization that recommends mammograms starting at 50. There's one that recommends starting at 40. And one of them recommends every year and one of them recommends every other year. So it's just good to know those things, because if you're going to a doctor that recommends one way and you want to do it the other way, you should do it the other way and find someone who will do that for you.
That is so important. And I will mention this as well, especially for people of color. We tend to run more often in managing or dealing with doctors or physicians who may not recommend us to step outside of the general guidelines. And this is where it comes so important for you to know your body, for you to be your own advocate as well. And as Dr. Henson is saying, if that doctor isn't flowing with you, there are other doctors who you can go to as well. And that is so important. And I wanted to mention one more thing again, before another question comes in, and that is know your family history, right? So not all the time do we know our family history. In my case, for breast cancer, like I told you, I didn't know a thing about breast cancer, nor anyone in my family who even had experienced breast cancer. It wasn't until after I had completed my first round of breast cancer treatment, I actually was at a retirement party for my dad back home in St. Louis, right? Family was there. And I was talking to my auntie about going through the breast cancer treatment. And then, guys, guess what? I found out that my father's mother had breast cancer. It metastasized, and she ended it spread in her body, and she ended up passing at that time, but the family had not shared that history going down the line. So know your family history, ask questions as well about your family history. I think, is there a question in chat here, Lisa?
It is, Mackenzie wanted to know, how did you keep a positive mindset through your treatment?
Right. Yes. So one of the pictures, and I had fun today going back and digging out these pictures. And guys, I got sort of lost going down memory lane with all the pictures. But one of the things that I did was surrounded myself with my support team. My support team made sure I was grounded in prayer. I was grounded spiritually, made sure I was eating, made sure that my friend Adam made sure that after every chemo treatment, we went and took pictures, and we would always go out to eat. And I will tell you guys, honestly, sometimes after my chemo treatment, I didn't feel like eating, but it was the part of the process of what we were doing, of enjoying life. And so surrounding myself with those who made sure I was grounded in all ways. And then also even on the job, I had friends on the job who introduced me to their dogs and would send pictures of their dog, Bill Davis, I'll throw your name out there, right? Who would do that to be sure that Karen Ivy had that happiness and had that surrounding viewpoint of keeping focused on celebrating life and focusing on healing and moving forward in life. But that's how I did it.
Miss Karen, it's Barbie. I have a question for you, a couple of questions for you.
Yes.
I love the idea of getting a support group. My sister's best friend was diagnosed right before her, but her treatment was a little different. But of course, she just got tested again and everything was negative. So they stay connected. But I like the idea of having that additional support group, women that are going through the same thing that she's going through. I think that would be great. But I wanted to ask about your annual visit. You mentioned annual OBGYN. So my annual appointment consists of with my primary care physician, which performs the pap smear, but not a dedicated OBGYN. Are you saying outside of that physician, still visit with your OBGYN?
If your primary care does do your total physical exam, that's fine.
Okay.
And so, yeah, and thank you for that question. More so the focus is being sure you are receiving that annual physical exam,
Okay.
right? For females.
Okay.
Yep. And also, like I said, asking your doctor if you have any questions regarding it as well. I'm going to make a statement too. And this was a study that was done, and some doctors here in Colorado even met some time ago and was talking about it. For people of color, sometimes as you are having your physical exams done, the doctor, him or herself, who may not also be a person of color, may feel a little awkward in doing that exam with you. And this was the feedback from doctors themselves. So here's my suggestion. If you are receiving your physical exam and you notice your doctor is going sort of fast around your breast, sort of fast even doing your vaginal exam and things like that, slow the doctor down. Talk to the doctor. Make sure the doctor is comfortable, because it's just a reality. We live in a very, very diverse world. And it's very typical for us to interface with individuals who may not be like us, may not even be from a background similar to ours. The question that I asked Dr. Henson about that importance of soft skills as well as technical skills is very real, especially for doctors. And so if you're ever in that patient position and you notice that your doctor may not that comfortable, moving a little fast, ask the doctor questions that will slow the doctor down and make sure that doctor, him or herself, is feeling very comfortable as they're working with you and working with your body.
Got it. Thank you.
Any other questions for Dr. Ivy? Well, I have one, and that'll give everybody else time to think of theirs. Most of the time when we hear the C word, it just kind of fills us with fear because nobody wants to hear that C word associated with them. How did you feel once, it was confirmed that you did have breast cancer?
Wow, you know what? Absolutely right, Lisa. You really are right. So when the doctor, well, first I'm going to be really real with how I even found out it was breast cancer. Real process, right? So I told you I found the lump myself. Something was feeling a little different. So I mentioned it to the doctor, who then took me through all the additional testing, tissue biopsies, as you check out in one, the mammography exam, they see it on the x-rays, they make that determination of, okay, I think you need to have go to the next step right there to determine if indeed this is indeed a lump or maybe fluid filled, right? You go through that process and then they do the tissue biopsy. In my case, if you're advancing forward, where they do want to continue additional checks. Now, guys, I received feedback from my tissue biopsy from a voice message that was left on my cell phone. And the voice message told me, sorry to tell you this, but your exams came back positive with cancer. So that's how I found out that I had cancer. I will not say that is most typical of offices. Over time, I ended up dropping that office and that doctor's office, but real story. So needless to say, the way that I found out and just finding out about it, period, I was crushed. Because like I said, I was very healthy. I was very athletic all throughout school. I would eat the right things. Even as an adult, I was still very, very athletic. And I didn't know of any history in my family of anyone dealing with breast cancer. And so that was a big, big whammy. It was like, hold the horses, right? Stop everything. And that's how I really received it. And that's how I felt. I felt really, really crushed. And so it took much. And this is where immediately my family and my friends, who first shared it with, first with family, and then I started sharing it with a little bit more people very slowly, because part of me still wanted to think this just couldn't be true. I know something was wrong, right, in it. But as additional tests were ordered and I went through all of those additional tests, which really confirmed the breast cancer, then it became something that you need to shift your mind as best as you can, Karen, to you need to start taking care of this and getting everyone, your team, medical team, in line who needs to work with you to take care of this. The support group, Barbie, the way that came about for me is I had gone to my church was having a breakfast celebration, and I was waiting in line to register to check in, and I hadn't seen someone at the table for a while, and I was sharing with her because she said, Karen, we have been missing you in church for a while. What's going on? And I was telling her I had been going through those treatments. It was actually a lady in front of me who was eavesdropping. She was listening to the conversation, and I'm so glad she was. Her name is Diane, and she had just gone through breast cancer treatments. And it was so from the conversation of Diane listening to mine that she said, Karen, I need to introduce you to Rosie. Rosie was another lady in our church who had dealt with breast cancer. And then we ended up getting a group of ladies together who had walked that walk and went through it. And that was the beginning of our breast cancer support group. But yes, Lisa, it was very crushing. And it took more than a second for me to get my mind together, moving from the highly emotional, as Dr. Henson had mentioned, into the very proactive and active stage of now building, working with my oncologist to build out my medical team for treatments.
Yeah, that is, I as a daughter, when I heard cancer for my dad, he was crushed and I was crushed, whole family was crushed. So I was just wanting to know, from your perspective, I knew it was crushing because it is, like I said, nobody wants to hear the C word.
Yes, and then imagine hearing it a second time, 15 years after going through that whole process. Oh, guys, you can only think. Hearing this a second time, so by the time that comes, and as I said, anyone who has gone through it, we immediately will remind everyone to check your body. The earlier you find out and confirm any situation of cancer, usually the better off it is. And in both situations, mine was found at a small stage, beginning stage, which was really, really good. And that has impacts on your treatments and success potential, life potential, and everything. And with the whole oncology field and talking with my doctor, like I said, you have to get your head mindset into that position of managing the situation, because your doctor will straightforwardly speak to you about treatments, the percentage of life sustaining after the treatment. They break it down. If you do this, these are the stats. If you do this, these are the stats. The importance of having a second set of ears with you is so important. Barbie, I applaud you for being there with your sister, because I can tell you sometimes what the person hears as the doctor is sharing all this information. The person is still hearing, and this will happen to me. I'm sitting here listening to the doctor, and in my mind is, did he say I had breast cancer? Right. And this is after several meetings when he is moving forward to talk treatments. So yes, it can be crushing. It is very crushing. Surround yourself by friends and family who can support you throughout each step of the way. Focus on your life, live life throughout the whole stage, because you will have a story to tell. And if you're supporting someone going through this, you still will have a story to tell of how you provided that support.
And we thank you, Dr. Ivy, for sharing your journey with us. I'm sure you have inspired those here today. And also, Dr. Henson had to go to another meeting, but we thank her for her time today and sharing with us about radiation oncology and how she got started in the field. And maybe something was said today that may get you thinking about, hey, STEM is in every area of our lives, even in something like a disease of cancer. And so that was our objective today, to broaden your mind and to have you to think about STEM is in everything that we do. And so we thank you all for attending today, and we appreciate you, and we hope to see you at our next event. I'm going to share my screen really quickly here. Give me a second. But we want you to connect with us. If you are not already connected with us on UAGC Connect, I would highly encourage you to do so. We post over there regularly so you can be aware of when our next events are, and as well as on our LinkedIn group. So if you haven't joined our LinkedIn group, we encourage you to do that too. And we also have two student officer positions that are available. We are looking for a secretary, and we are looking for a communications officer. If you are social media savvy, or you want to get more social media savvy, then hey, this would be a good role for you. And it's also a good resume builder. So hey, it is always a good idea to add that to your resume. And I always like to learn something new. And so that could be you. If you are interested in either one of those positions, go ahead and email us at wis@uagc.edu. And I'm going to stop sharing and be on the lookout. We are going to have a awesome event in April. If you are an introvert, then you don't want to miss the event that's coming up. We're going to have the flyer is going to be distributed, so don't worry. We're going to make sure that you get it. But we are going to be discussing being an introvert and how that translates over into the STEM field as well as careers. And our very own Catherine Robinson, who's our president, is going to lead the discussion. So you don't want to miss that. So just stay abreast on UAGC Connect as well as on our LinkedIn group, so that you can know when we are going to have that event available. And this event will be posted on our LinkedIn group as well as UAGC. Give it Tuesday. Just give it Tuesday. We'll have it posted for you. So if you know someone that could benefit from this, feel free to share. And so with that, I am going to wish you all a good weekend. Once again, thank you for joining the Women in STEM. And we look forward to connecting with you again in April. So take care and have an awesome weekend.
Thank you. You do as well.
Thanks,
Thank you.
everyone.